All right, let's get the grand round started. Dr. Ardhanari is going to talk to us today about cardiovascular prevention in pediatrics. Mohanageetha is a third-year soon-to-be graduating resident. And this is one of the obligations of our third years that they all give a grand round. So, Mohanageetha, let her get started.
Thank you so much, Dr. Vakini. Good morning, everybody. I'm Dr. Ardhanari. As Dr. Vakini said, I'm one of the third-year residents. I'm here to present my grand rounds on cardiovascular prevention in pediatrics. Why this topic? Atherosclerotic cardiovascular disease is a leading cause of death in adults in the United States. Hence, the pressing need for comprehensive guidelines-based, evidence-based guidelines for cardiovascular prevention in pediatrics. I have no conflict of interest or financial interest to disclose. The objectives of this grand rounds is going to be a detailed discussion on 2001 guidelines from National Heart, Blood and Lung Institute, which outline cardiovascular risk factors in childhood as listed below. Family history of premature CAD, nutrition and diet, physical inactivity, tobacco exposure, high blood pressure, dyslipidemia, obesity, diabetes mellitus and other special risk conditions, risk factor clustering and perinatal factors, which could contribute to adverse cardiovascular outcomes later as an adult. Also to discuss two primary pediatric goals to prevent atherosclerosis, which is primordial prevention, which again is defined as prevention of development of risk factors associated with atherosclerosis, and primary prevention, which is identification and effective management of identified risk factors for prevention of CVD. We're also going to discuss the integrated cardiovascular health schedule to be followed by primary care pediatrician. Before going on to the guidelines proper, a few words about NHLBI. In 2006, the director of NHLBI, Dr. Elizabeth Nebel, appointed an expert panel. The expert panel reviewed evidence extending back to 1985. The whole process of evidence review is complex and extensive, and the expert panel published the guidelines in 2011. The guideline development process, as said, was extensive. It involved electronic search. The initial group of more than 1 million titles published between 1985 and 2007 were reviewed. And the search was refined to include 648 studies relevant to pediatric CVD prevention. As listed below, it included 293 RCTs, 50 systematic reviews, 33 meta-analysis, 194 observational studies, and 78 sets of guidelines. And all the guidelines were abstracted into evidence tables, which we're going to discuss further. On to the right are some of the selected epidemiological studies that has been included in the evidence review. NHLBI adapted evidence grading system from American Academy of Pediatrics. Grade A being evidence from well-designed RCTs or diagnostic studies. B being RCTs or diagnostic studies with minor limitations, genetic natural history studies, overwhelmingly consistent evidence from observational studies. C being observational studies, case control or cohort design, and D being expert opinion, case reports, and reasoning from first principles. So what is the rationale for this guideline from NHLBI? As we all know, although cardiovascular diseases, manifest cardiovascular disease is uncommon in pediatrics, but the pathological process for clinical CVD, which is the atherosclerosis, originates in childhood. Development and progression of atherosclerosis relates to the number and intensity of CV risk factors, which can be identified in childhood, and CV risk factors tend to track from childhood into adult life. And interventions do exist for management of CV risk factors, hence the rationale for guidelines. A few words about the natural history of atherosclerosis. Endothelial dysfunction mentioned on to the left is the primary precipitating event for the development and progression of atherosclerosis. The first lesion mentioned, initial lesion and fatty streak or early lesions caused mainly by intracellular lipid accumulation. And the onset can be from first decade, depending on the number and intensity of risk factors. The early lesion can progress to intermediate lesion and atheroma when there are extracellular lipid deposits, and the onset can be from third decade, and it can progress to fibroatheroma and complicated lesion when there is fibromuscular layer deposition over the lipid core. So we are more concerned about, as pediatricians, we are more concerned about the initial lesion and fatty streak, and which can be prevented by lifestyle modification. Evidence of atherosclerosis in childhood is from direct and indirect evidence. Direct evidence links risk factors in childhood to atherosclerosis and atherosclerosis at autopsy. There are several studies which demonstrate strong correlations between presence and intensity of risk factors and extent of atherosclerosis at autopsy. Indirect evidence links risk factors in childhood to atherosclerosis assessed non-invasively. In the past decade, there are several measures of subclinical atherosclerosis, including coronary calcium on electron beam computed tomography, increased medial thickness in coronary artery assessed with ultrasound, endothelial dysfunction assessed with brachial ultrasound imaging, and increased LV mass assessed with echo. On to family history of premature CAD, the first and one of the most important and independent risk factor for CVD later in life. Family history of premature CAD is defined as premature being defined as a first degree relative, a male parent, sibling, grandparent, or uncle before 55 years of age, or a female parent, sibling, grandparent, or aunt before 65 years of age. And coronary artery disease is defined, includes myocardial infarction, treated angina, stroke, sudden cardiac death, percutaneous coronary intervention, and CABG. The role of primary pediatrician is to evaluate for family history of premature CAD at the initial encounter, anytime between birth and 12 months of age, and to reevaluate at 3 years, 9 to 11 years, and 18 to 21 years. Once a positive family history of premature CAD is noted, evaluate patient for other CV risk factors and evaluate family, especially parents, for CV risk factors. On to nutrition and diet. The ongoing challenge is to increase intake of fruits and vegetables and to decrease sugar intake in kids. As of now, 1 in 3 kids eats fast food every day, and a fifth of teens drink the equivalent of an extra meal in sugar-sweetened beverages. Here are the 8 specific recommendations for primary care pediatrician on nutrition and diet. Exclusive breastfeeding is strongly recommended for kids between 0 and 6 months. Between 6 and 12 months, continue breastfeeding until 12 months. If breastfeeding is not possible, then transition to iron-fortified formula until 12 months. And to limit other drinks to 100% fruit juice without any added sugar, and to limit the quantity to less than 4 ounces a day. Regarding fat and energy intake, there is no restriction for kids below 12 months of age. Between 12 and 24 months, transition again to reduced fat, unflavored cow's milk. The choice between 2% and fat-free is decided based on growth, appetite, intake of other nutrient-dense foods, and other sources of fat, and also the potential risk for obesity and cardiovascular disease. Transition to table food is recommended with the fat content mentioned below. The total fat content should be restricted to 30 to 40% of daily calories, and saturated fat to 8 to 10%, mono and polyunsaturated to 20%, and cholesterol to less than 300 milligram per deciliter, and to avoid trans fat. The supportive actions recommended are to encourage DASH type diet, which is dietary approaches to stop hypertension. And the diet is rich in fruits, vegetables, whole grains, and low fat, and it's low in sugar. And it's proven to decrease hypertension, the incidence of hypertension later in life. For kids between 2 and 10 years, again, the fat-free unflavored milk is the preferred beverage. And again, to limit to naturally sweetened juice to 4 ounces a day. For kids with special risk factors and family history of CV risk factors, they should be transitioned to Child 1 type diet at around 2 years of age. Child 1 type being described as a fat content. Described based on fat content, the total fat content should be limited to 25 to 30%, unsaturated fat to 8 to 10%, and mono and poly unsaturated fat to 20%, cholesterol again to less than 300. Other supportive actions are summarized onto the right. To increase the fiber intake to H plus 5 grams a day, and to limit sodium to less than 6 grams a day. Again, DASH diet should be encouraged, and a healthy eating habit should be encouraged, like breakfast every day, eating meals as family, and limit fast foods, to mention a few. Between 11 and 21 years, again, the preferred beverage is fat-free unflavored milk. Again, limit to naturally sweetened juice to 4 to 6 ounces a day. The fat and energy intake is again same as above, and to increase the fiber content to 14 grams for every 1,000 kilocalories of energy intake. Here's a recommendation on age and gender specific caloric requirements by activity level. Sedentary lifestyle includes only light physical activity associated with typical day-to-day life. Moderately active life includes physical activity equivalent to walking 1.5 to 3 miles a day at 3 to 4 miles an hour. An active lifestyle includes physical activity equivalent to walking more than 3 miles a day at 3 to 4 miles an hour. On to the recommendations on physical activity. American Heart Association recommends at least 60 minutes of moderate to vigorous intensity aerobic activity every day. And as of now, again, less than 3 in 10 high school students get at least 60 minutes of physical activity every day. Evidence links physical activity patterns, dietary choices, and smoking behaviors, and they tend to interlink. Here are the recommendations on physical activity. Between 0 and 12 months, the pediatrician should encourage parents to create an environment promoting and modeling physical activity and limiting sedentary time, and to discourage TV viewing altogether. Between 1 and 4 years, parents should encourage unlimited active playtime and safe supportive environment. And again, for kids less than 2 years, discourage TV viewing, and 2 to 4 years, limited to 1 to 2 hours a day. For kids between 5 and 21 years, moderate to vigorous activity like jogging or playing baseball 1 hour a day, and vigorous physical activity like running, playing singles tennis or soccer 3 days a week is recommended. Limit leisure media time to 1 to 2 hours a day. And there are some supportive actions mentioned to discourage TV in child's bedroom, encourage family activity at least once a week. The pediatrician should take activity and screen time history at every visit, and they should encourage parents to match physical activity with energy intake for the child, and to support recommendations for daily physical education in schools. On to tobacco exposure. Tobacco exposure in children can occur in 3 different ways. In utero exposure from maternal smoking, involuntary tobacco exposure from secondhand smoking at home, and voluntary tobacco use. Now, nicotine is one of the most addictive chemicals known to mankind, and once there is a positive smoking history as a child, 50% of them tend to smoke as adults. Burden of the problem. Here's the graph mentioning. Here's a graph from National Youth Tobacco Survey and National Survey on Drug Use and Health from 2010, showing percentage of middle school, high school, and young adults who currently smoke cigarettes. About 7.7% of middle school students and 24.6% of high school students reported smoking. And as mentioned before, 50% of those who smoke in childhood continue to smoke as adults. Tobacco use is harmful and addictive in all 3 ways as mentioned before, and there is a pressing need to reduce tobacco exposure. There comes a role for primary pediatrician. During well child visit, when mom is pregnant with the next child, elicit maternal smoking history and provide smoking cessation assistance or referral to parents. Between 0 and 9 years of age, encourage smoke-free home, and again provide smoking cessation assistance or referral if parents are smoking. From 9 years onwards, you can provide active anti-smoking advice by using 5A questions: ask, advise, assist, and arrange. You can assess readiness to quit, and you can assist by providing resources for smoking cessation. We have quit line number, we have community cessation resources, and we can provide information about pharmacotherapy to assist in cessation. And the pediatrician should advocate for school and community-based smoke-free interventions. On to the next well-known cardiovascular risk factor, hypertension. Here are some facts. Between 2003 and 2006, in children between 8 and 17 years of age, the prevalence of pre-hypertension was 14% in boys and 6% in girls, and amongst those, 7% progresses to hypertension every year. The prevalence of hypertension again is between 3 and 4%, and hypertension persists in 1/3 of boys and 1/4 of girls on a 2-year follow-up. Here are the screening recommendations for hypertension. For kids beyond 3 years of age, annual blood pressure measurement in all is recommended, and the blood pressure is interpreted for age, sex, and height. We have blood pressure percentile charts, as we all know. For kids between birth and 3 years of age, no routine blood pressure measurement is recommended unless the patient has a history of prematurity, very low birth weight, or other neonatal complications requiring ICU care, congenital heart disease, recurrent UTI, hematuria or proteinuria, renal disease or urological malformations, solid organ or bone marrow transplant, malignancy, drugs known to raise blood pressure, systemic illnesses known to cause hypertension, and family history of congenital renal disease. Here is an illustration about the appropriate way to measure blood pressure and how to categorize them. Use appropriate blood pressure cuff size for age. Measure BP at each well-child visits beyond 3 years, as mentioned before, and several studies shows that auscultatory method is a preferred method to measure blood pressure. Measure height, weight, and BMI at every visit, and determine BP category for age, height, and gender, as mentioned before, from the blood pressure percentile charts, which is age and gender specific. Categorize blood pressure as normal, pre-hypertension stage 1 and 2. If it's below 90th percentile, it's normal. Between 90th and 95th, it's pre-hypertension, and the blood pressure should be repeated in 6 months. If it's between 95th and less than 95th percentile plus 5 mm Hg, it's called stage 1, and it should be repeated in 1 to 2 weeks to confirm and to recategorize. If it's more than 99th percentile plus 5 mm Hg, it's called stage 2 hypertension, and it should be evaluated straight away or treated within a week. For kids with any blood pressure category, encourage on child 1 diet. As mentioned before, child 1 diet has restricted fat and energy intake, and DASH diet again has recommendations on increased fruits and vegetable intake, and to increase intake of grains and to decrease intake of sweetened beverages. That again is proven to decrease blood pressure. Counsel on activity, increasing activity, and counsel on weight management if necessary. Here's an illustration on management of hypertension. As mentioned before, if it's categorized as pre-hypertension, then initiate diet and activity education and weight management, monitor every 6 months. If after 6 months the patient is again categorized as pre-hypertension, then initiate basic workup, and if the basic workup is negative, then monitor every 6 months. More about basic workup later. For kids with stage 1 hypertension, initiate basic workup at the initial encounter once it's confirmed. With a complete history and physical, perform CBC-UA, lipid profile and fasting glucose, and perform renal ultrasound to look for secondary causes and cardiac ultrasound to look for end organ damage. If the basic workup is negative, then go for lifestyle management, and then monitor every 3 to 6 months. Initiate antihypertensive medications if there is no improvement on follow-up, and then monitor every 3 to 6 months again. If any of the basic workup is positive, then initiate antihypertensive medications and treat the secondary causes, and monitor every 3 months. If it's stage 2 hypertension, initiate basic workup straight away again, and consult hypertension expert. Initiate antihypertensive medications and treat secondary causes as like stage 1, and follow closely like every 1 to 2 weeks until blood pressure is controlled, and then every 1 to 3 months thereafter. Here's the goal blood pressure that's mentioned. It should be maintained below 95th percentile for age, sex, and height if there are no risk factors, but if there is diabetes, chronic kidney disease, or target organ damage, then it should be maintained below 90th percentile. On to dyslipidemia. About 10.8% of adolescents between 12 and 19 years have an elevated total cholesterol more than 200 milligram per deciliter. About 23.2% have elevated triglycerides, and 23.4% have low HDL. The reason for the major surge being major increase in prevalence of childhood obesity, which has tripled in the last 30 years. Since obesity is associated with combined dyslipidemia, there is a major surge in the prevalence and incidence and prevalence of dyslipidemia. With obesity, obesity is associated with combined dyslipidemia, as mentioned before, which has moderate to severe elevation of triglycerides, mild elevation of total cholesterol and LDL, and low HDL. Hence, the need for complete lipid, serum lipids and lipoprotein panel for screening and for management, for planning the management. So here is the definition of dyslipidemia. We have values from National Cholesterol Education Program Expert Panel. The acceptable value for each cholesterol and triglyceride category is less than 75th percentile for acceptable, between 75 and 95th percentile for borderline, and more than 95th percentile for high. And we use non-HDL cholesterol for screening purpose, and LDL cholesterol and triglycerides to formulate a plan for management for drug therapy. And we have values for HDL and ApoA as well. So here is a recommendation on lipid screening. What about universal lipid screening? It's recommended between 9 and 11 years and 17 to 21 years. So why between 9 and 11 years? Because there is a strong correlation between lipoprotein levels in late childhood and adulthood, and also the total cholesterol and LDL cholesterol falls by 10 to 20% during puberty. Hence measurement of cholesterol during puberty gives false negative results. Hence 9 to 11 years is the right age. And also statin therapy can be initiated for kids above 10 years of age. Hence 9 to 11 years is the ideal age for universal lipid screening. And why non-HDL cholesterol? Because it's easily calculated from total cholesterol, subtracting HDL cholesterol from total cholesterol. And it's a significant predictor of presence of atherosclerosis from many studies, and can be accurately calculated in a non-fasting state, hence the ideal screening tool. For kids between 2 and 8 years and 12 and 16 years, or before that, if the non-fasting lipid profile is abnormal, it has to be confirmed with fasting lipid profile times 2. And also, there is no recommendation for lipid screening for kids below 2 years of age. And for kids between 2 and 8 years and 12 and 16 years, fasting lipid profile times 2 should be done only if there is risk factors like diabetes, hypertension, obesity, or smoking, and there is moderate or high risk medical condition, or there is a family history of CAD. Once high LDL is confirmed with fasting lipid profile times 2, it can be categorized as LDL between 130 to 250 or more than 250, and here's the algorithm to manage high LDL. If it's between 130 to 250, exclude secondary causes, evaluate for other CV risk factors, start child 1 diet, observe for 6 months, repeat FLP. If there is no response, start on child 2 LDL diet, which again is described here. To limit saturated fat intake to less than 7% as against 8 to 10%, and cholesterol to 200 milligram a day as against 300 with child 1. And initiate lifestyle changes, monitor for 6 months, and repeat FLP, and again categorize based on LDL levels. If it's less than 130, reinforce child 2 LDL diet and follow every year. If it's between 130 and 190, intensify child 2 LDL and follow up every 6 months. If it's more than 190, or if it's between 130 and 190 with associated CV risk factors, initiate statin if more than the kid is more than 10 years of age. And again, if LDL is more than 250, consult lipid specialist for drug therapy. Here is the algorithm for management of high triglycerides. For kids below 10 years of age, if the triglyceride is between 100 and 500, or between 10 and 19 years, if it's between 130 and 500, initiate child 1. Switch to child 2 triglyceride diet, which again is mentioned here. There should be decreased sugar intake, simple carbohydrates should be replaced with complex, and there should be no added sugar, and to increase dietary omega-3 fatty acid. And initiate lifestyle modification. Repeat FLP after 6 months and decide on the management plan based on triglyceride levels. If it's between 200 and 500, refer for drug therapy and initiate omega-3 fish oil. If it's more than 500, consult lipid specialist for drug treatment. To obesity, which is one of the major independent risk factor for future CVD. The definition is based on American Medical Association, CDC, and Maternity and Child Health Bureau Expert Committee. Obesity is defined as BMI more than 95th percentile or greater, and overweight is between 85th and 95th percentile. So why is BMI chosen to be the screening tool for obesity? Because it's easily calculated as weight divided by height squared, and it correlates strongly with direct measures of body fat. A word about obesity tracking into adulthood. 84% of kids with BMI between 95 and 99th percentile tend to be obese as adults, and 100% if BMI is more than 99th percentile. And obesity is one of the strongest, one of the most important CV risk factor, which tends to track into adulthood. For kids between 2 and 19 years of age, 17% of them are obese per 2011 to 2012 data. It has tripled in the last 30 years, as we can see from the graph. Between 1971 to 1974, the incidence was around 5%, and it has increased to above 15% in 2007 to 2008. Increasing percentage of kids between 6 and 11 years are becoming obese, and increasing percentage of Hispanics who are becoming obese. Here is a map from Youth Risk Behavior Survey 2013, illustrating percentage of high school students who were obese in selected US states. As we can see, Louisiana has 14% of obesity in childhood. And obesity is directly linked to poverty. Of the 10 states with the highest obesity rates, 9 states rank among the nation's poorest. We have some interesting facts on childhood obesity. 1 in 3 children between 2 and 19 years are considered overweight or obese. 2 out of 3 don't get any physical activity, and 96% of elementary schools offer no physical education classes. And kids spend about 7 hours in front of TV or computer screens every day, as against 1 to 2 hours, which is recommended. Here's a specific recommendation for management of obesity. For kids less than 6 years, there is no data available on weight loss programs. For those between 6 and 12 years, family-based programs are recommended, and parents should be the focus of intervention. Family-based programs are known to be effective at initiating and sustaining weight loss in kids between 6 and 12 years. Whereas for adolescents, the family-based programs are effective at initiating weight loss in short term, and adolescents should be the focus of intervention, whereas behavioral change programs involving peers are associated with more sustained weight loss. Medications are recommended for kids with BMI above 95th percentile who fail comprehensive lifestyle weight loss program, and bariatric surgery is recommended for BMI more than 95th percentile and associated comorbidities. A few words about the medications used for management of obesity. Orlistat has been approved by FDA for 12 years and older for weight loss in conjunction with reduced calorie diet. It's associated with high rate of GI side effects, and labeling has been updated to incorporate safety information pertaining to occurrence of rare cases of severe liver injury. Metformin again is approved by FDA for 10 years and older with type 2, but it's not approved for weight loss for either children or adults. So once we have a kid with obesity, we should evaluate for all other risk factors, as 70% of obese kids have at least one associated CV risk factor, and 39 have 2 or more. On to the special risk conditions which can accelerate atherosclerosis in childhood. We have high risk conditions which are associated with manifest CAD before 30 years of age, and moderate risk conditions which can present as accelerated atherosclerosis before 30 years of age without any manifest CAD. Among high-risk conditions, type 1 and 2 diabetes tops the list. Chronic kidney disease, post-renal transplant, post-heart transplant, and Kawasaki disease with current. Kawasaki disease with concurrent coronary aneurysms are amongst the high-risk conditions. Moderate risk conditions includes chronic inflammatory disease like SLE, JIA, HIV, and nephrotic syndrome. A few words about the trend of type 1 and 2 diabetes. As mentioned before, they are significantly associated with increased risk of accelerated atherosclerosis, and they represent the prototype of special risk conditions, again associated with accelerated atherosclerosis. Type 1 DM, as we can see from the graph, 25% are diagnosed between 5 and 10 years of age, and 40% are diagnosed between 10 and 15 years of age. For type 2 DM, as the prevalence of obesity is increasing number of children have type 2 diabetes. As we can see, 30 to 40% of childhood DM is type 2. Here again is an illustration as obesity rises from 4% in 1985 to 20% in 2008. So does type 2 diabetes from 2% in 1985 to 30 to 40% in 2005. Here's the screening recommendation from American Diabetes Association for type 2 DM. So whom to screen? Kids who are overweight with BMI more than 85th percentile for age and sex, with any two of the below mentioned, family history in first or second degree relative, high risk race or ethnicity, and who have signs of insulin resistance or conditions associated with insulin resistance, like acanthosis nigricans, hypertension, dyslipidemia, and PCOD. Should be screened with fasting blood sugar starting at 10 years of age or at onset of puberty and every 2 years. Here is an illustration for risk stratification and management of special risk conditions. Again, step 1, as mentioned before, should stratify the disease process as high risk or moderate risk. They are listed here. Step 2 is to assess the associated CV risk factors. And the CV risk factors that we discussed so far has been listed here. Step 3 is to establish tire-specific cutoff points and treatment goals. For high-risk conditions, we should have a low threshold for treatment, and they should be treated. It should be associated with intensive lifestyle management. BMI should be, the goal for BMI should be less than 85th percentile, blood pressure should be less than 90th, LDL below 100, triglycerides below 90, non-HDL below 120, and fasting glucose below 100. Step 2 is lifestyle change, and the tire-specific cutoff points are met with intensive lifestyle management, child 1 diet, increasing activity, and weight loss as needed. And step 5 is drug therapy for the specific conditions mentioned above for the high risk and moderate risk conditions. On to the risk factor clustering. The well-known cardiovascular risk factors like obesity, hypertension, and dyslipidemia tend to cluster and is called the famous metabolic syndrome. Cardiovascular risk behaviors like smoking, suboptimal diet, and sedentary behavior tend to cluster. So do advantageous diet and exercise habits. A few words about metabolic syndrome. It's defined as 3 or more of the following risk factors: elevated waist circumference, elevated triglycerides, blood pressure, and fasting glucose, and reduced HDL cholesterol. As per NAINS data from 1999 to 2002, the prevalence of metabolic syndrome is between 2 and 9.4% for all teens, and 12.4 to 44.2%, which is close to half of obese teens. About the pathophysiology of metabolic syndrome, visceral adiposity and insulin resistance plays the primary role in the development of metabolic syndrome, which can lead to dyslipidemia, hyperglycemia, inflammation and oxidant stress, thrombophilia, and hypertension. Metabolic syndrome is not considered a separate risk factor. It is a cluster of risk factor and is difficult to treat. Since visceral obesity plays a central role in the pathophysiology, prevention of obesity is the most important strategy to lower prevalence of metabolic syndrome. Management is to intensify weight reduction with emphasis on lifestyle modification, intensification of management of identified risk factors, prompt evaluation for DM liver function abnormalities, LVH, and sleep apnea, and to consult endocrinology if it's refractory to the above management. On to the last and final CV risk factors. Adverse perinatal factors like maternal obesity and maternal smoking can contribute to adverse cardiovascular outcomes later in life. Maternal obesity is known to cause gestational diabetes, hence causing maternal hyperinsulinemia, hyperglycemia, and dyslipidemia, which in turn can cause fetal in utero pre-programming, which later can cause adult obesity, type 2 diabetes, heart disease, and hypertension. And maternal smoking, as mentioned before, in utero exposure can increase the adverse cardiovascular risk, cardiovascular outcomes later in life, causing endothelial dysfunction and increasing atherogenesis. The role for pediatric care providers is to advocate for parental smoking cessation to promote a smoke-free environment for children. And again, provide smoking cessation assistance as mentioned before. These are my references. Again, this is, I thought this is interesting. 5210 to remember, 5 fruits and veggies a day, limit fast food, eat meals as a family, watch portion size and eat breakfast daily, 2 hours or less screen time, no TV in the bedroom, 1 hour or more of physical activity, and no added sugar. Thank you.
Thank you, Geetha. Open for questions. So it looked like from the references that you had that the American Academy of Pediatrics has signed on to these guidelines.
Right.
And everybody's in agreement.
Right. So this was published in 2011, and everybody, like it's a combined, it's a combination of all guidelines from well-known expert panels.
Okay.
Right.
Dr. Koo? And then
That was very nice. I'm just curious on all the presentation you showed. Post-cardiac transplant is a risk factor for cardiovascular diseases and atherosclerosis. I'm just curious that other solid organ transplantations are not listed because chronic renal failure, hypertension, renal transplant. Is there any particular mechanism that you know of why the heart transplant seems to be sticking out versus there's no mention of renal transplantation and other solid organs?
That's an interesting question, but I don't have an answer to that. I'll look that up.
My
John?
sort of sense is that this has been very high on the list for propaganda for at least the last 15 years or so. Is there any data that we may be influencing what's happening with obesity and some of these other things? I know smoking's going down. That's got to be a real plus. But is there anything else that we're making any progress? Or we still a work in progress? We still like Sisyphus rolling the boulder up the hill.
In one of the studies that I came across, there was a projected graph for obesity, and it was projected to 2022, where 100% of kids are going to be obese.
You know, I can remember everything when Susskind
Because
was
it's-
making a big deal about losing weight and keeping it down. Is there any data that if you intervene and you can get them to lose weight, that they're likely to keep it up over more than 6 months to a year?
I don't know, but I do know that the...
I don't mean to be the naysayer, but I'm trying to look for gleams of light on the horizon.
I think that the most recent data from the CDC was that this was the first time there was a decrease in obesity rates amongst children. So that we may be having an effect in at least preventing obesity.
Yeah.
Now, in terms of managing it once it happens, I think that's different, and there is data, but sustainability is a big issue. So, John?
I think one of the biggest problems is that in our patient population, how do we translate this into a parent knowing
Right.
what's the difference between 20% fat and 10% fat and cholesterol and all those things?
Right.
And it gets down to practical questions like, my child won't drink milk unless I put chocolate in it. And so how do we balance even that simple question? Is it better to have sugar sweetened milk to get them to drink it or no milk at all?
That's a very practical question. We do have examples for model diets for DASH type diet and child 1 diet. And there is the whole recommendation is up here. I didn't put that up on there. And we do have handouts for parents as to what to follow for the model diet for child 1. We do have. And probably we can have those handouts printed, have it in the clinic.
Monica.
I'm
I must congratulate you alluding to or addressing a very important preventive topic both for adolescents and adults. I was very privileged to attend a conference, international neonatology conference, and one of the keynote speakers who got a Lifetime Achievement Award was an Indian guy who was following up. For the first time he presented, which will be published in Lancet soon, the Parker's hypothesis, which you were alluding to in your last two slides, that he followed these babies up from in utero all the way into adulthood. He measured their growth, he measured the rapidity of growth in infancy, and looked at hypertension, cholesterol profile, and so on and so forth. And again, the problem of what I understood from his presentation is the preventive aspect. There is no good data that you can prevent that. Having said that, I want to make one comment which is well established in both animal experiments as well as in neonatology. You mentioned prematurity several times.
Right.
However, the data clearly showed it's not prematurity, but two other factors: the growth retardation, which is common in certain epidemiological studies in several countries, and that's what Parker's hypothesis was based on, as you know. Number two, in neonatology, what has been shown in premature babies, particularly, we guys thought we got to fatten them up, so you feed them more, but
Right.
that is dangerous.
Right.
The rapid weight change in early infancy. Perhaps Dr. Pu or somebody else can comment on it too. And now the consensus is that you don't do that.
Right.
So perhaps, do you want to address anything from your reading?
Right, exactly. But for since this is more about perinatal factors and more related to cardiovascular risk factor, which are associated with maternal adverse risk factors. They've not addressed any of this in this article, but I did come across an article which mentions that increased feeding and increased weight gain in the first few months for preemies is a major risk factor for later.
Just like in internal verities, that a little bit is good, more is not necessarily
Right.
good. I think that
Right.
often we forget that.
All right. Ms. Hunt.
This was a very nice overview. Thank you very much. I would like to touch on a few things. First, about Parker's hypothesis. Yes, we learned a lot from that, and that also relates to intrauterine glycemic exposures. And interestingly, that so that group looks into IUGR and how the risk increases in the upcoming years for metabolic syndrome, clustering of the risk factors, and other. Also, there have been interesting studies in Native American Indians, and not only SGA but LGA babies are also likely to develop future problems with metabolic syndrome, type 2 diabetes, and as you may know, type 2 diabetes is very prevalent in Native American Indians, up to 50% of the individuals. Also, with this opportunity, I would like to say that as the Department of Pediatrics, we have had some exciting developments in this area with the support of our department and the institution. We have been able to recruit a nurse, and we are still in the process of developing this clinic, Children's Health, Weight and Activity Clinic. And how this works is any of our clinicians, our residents, our general pediatrician subspecialists, when you see a patient in your clinics and do your usual assessment, assess the growth chart, body mass index, and if you have a child with body mass index greater than 85th percentile, you do your routine evaluation. And we also published an algorithm in our residence handbook, which may be helpful, and you mentioned all of those, and the hypertension evaluation. You can refer those patients to Ms. Amanda Duncan, Mandy, and it is under EPIC actually, it's Children's Activity Clinic. So you could refer, but under your care, that patient is still your patient, but Mandy can counsel them, get a very comprehensive diet, nutrition, and physical activity history. And we also developed a basic program just practically addressing these issues, because we know our parents are busy, economics are in difficult condition, but we developed a few basic topics. Every child needs to start the day with a good breakfast. We have to reduce the intake of sugars, sweetened beverages. what alternatives do we have? We can have fruit infused water. It's very economical. You don't need any specific devices to prepare that. And we have handouts for these. And Mandy has been in touch with our nutritionist. She has also developed, we have also developed some menus for breakfast. So we have a lot to offer. I say we because we started as the endocrine, but this is part of our general pediatrics clinical operations. So feel free to refer. But of course, along the line, if you see something which requires referral to gastroenterology or nephrology or endocrine, we'll be glad to take care of those patients. And I know this has taken long, but one more thing I would like to address. American Diabetes Association published those guidelines for diabetes screening many years ago. That dates back to, I believe, 2005, if not 2000. So in practical use, I do a little more than that because of the experience we have. First of all, if we just screen with fasting blood sugar, we may miss up to 30% of an abnormal 2-hour blood sugar in an OGTT or controlled postprandial study. So with those kids whom we feel have many of those risk factors, we would go ahead and also do a hemoglobin A1C level. And if it is in the gray zone, 5.7 to 6.4, which could lead to prediabetes, and this has been now well published and well accepted for the standardized assays, we are likely going to do a 2-hour baseline OGTT for them. So as endocrine, we'll be glad to contribute to the care of those who need that specialty care. But Ms. Mandy Duncan will be glad to see your patients and follow them with you. Thank you.
Yeah, that's a great resource.
Mandy, does your, Dr. Nessa, does your group work with the schools or the parent groups in the community? Because the idea of our presentation is to prevent it in early preschool or early childhood. So if they go to preschools or they go to elementary schools and give advice there, hopefully you won't see it in your clinic.
So actually what we have done, and Dr. Bocchini was very kind to introduce us to the Community Foundation years ago, and we became part of a collaborative group and then developed some collaborators, and we are still in touch with them. And what we have been also doing is going to the schools at the beginning of the school year, and Mandy has been instrumental this school year. Some of them I participated in the earlier years. So we make a presentation to the parents. We even take them fruit-infused water for them to taste. And we did this actually. University Health had a back-to-school backpack day, and we participated there. Some of our residents also nicely collaborated with us. And the attendance was tremendous. That was wonderful. I think at least 200 people came through our booth. So we tried to do community activities, and part of our effort with the activity clinic is we have links to YMCA, SPARS, the city parks, and agriculture center. So the goal is to also make our families aware of those free activities in the communities. So this is still a work in progress, and in the near future, we are hoping to expand this a little more, but we have made some progress, and it's still going.
And Allied Health has an inner city garden project that some of you may not be familiar with, where they've taken land that's been laid fallow, where they have, actually developed, gardens, because fresh fruits and vegetables particularly are very difficult to obtain in our inner city areas. And people have to travel to different, basically grocery stores. And with the superstores, they're becoming further and further out from the inner city and much more difficult to get to, particularly if you don't have transportation.
I don't really mean to sound like the grumpy old man, but so often we try to do things, and how effective are we? Such as, I'm all for the inner city garden, or how much of it are those who take advantages of those activities? Those who use it are the least likely to need it, it seems to me. And then the other thing is, we tell everybody rest is best, but the state will spend millions of dollars a year supporting formula, but how much do we really spend encouraging and otherwise hate to say forcing, but gently encouraging people to breastfeed. And we do so much, we know that what they feed has to be at home. And I know it's a devil's choice, but what do? We feed them at school. And they end up throwing probably at least a third to half out every day from people I talk to. And then we go ahead and feed them breakfast in the morning. And out where I live, because they're afraid people aren't eating, they give them backpacks, and on Friday they send them home with food to last them over the weekend. And at the same time, we're then removing the society stresses and everything from the family to properly feed them. And I know we're doing all of this for all the right reasons, but is it the most effective use of our resources? And I think that's one of the things we have to think about. How are we going to be effective? Not just do like I tell you, but how do we, the challenge is how do we achieve these things?
You have a question?
Last time I forgot.
One more question. I'm going to give you another question.
A lot of things have cut out. Physical activities, go to compensate for that. A lot of schools and
Yeah, but I-
meal planning. Do you think that's had any impact on childhood?
Primarily Hispanic communities, the people.
I'm sorry,
Literally,
get back to
they-
page of
Schools
physical
are shut
education.
down PE.
Right,
And these are people who never
Played
get
a role
ready.
in
right. So as I mentioned before in one of the slides, yeah.
Or do you just give up the freedom?
As mentioned before, the question was all the schools is cut out the time spent on physical education classes at school, and does it have an impact on incidence, prevalence of childhood obesity? As mentioned here, 96% of elementary schools offer no physical education classes these days, and it did contribute to the rising prevalence of childhood obesity. Yeah.
All right, in the interest of time, we need to cut off this discussion, but thank you again, Lisa, very much.
Thank you so much.